Good evening, everyone. Today we will have a quick recall session on the questions from the emergency medicine and critical care side for the previous NEET SS 2024 paper. We had very few questions, only 9 questions, but that's a lot from emergency medicine and critical care for the medicine paper, and of which 7 questions were from toxicology. All were relatively basic questions. So let's go through each one of them. First one, a 21-year-old male presented to the ER in altered sensorium with difficulty in breathing. On examination, found to have pinpoint pupil, which is suggestive of opioid toxicity, which is a classic presentation. Now, the patient was administered naloxone for opioid toxicity. Understandable, right? His condition improved partially only, but his condition improved significantly after administering flumazenil. So this is basically a question to know if you know about the antidotes of all these toxicological substances. So what is the likely substance he ingested? All right. So naloxone is the antidote of opioid and flumazenil is the antidote of benzodiazepines. So a combination of these drugs is the answer. So the answer would be opioids plus benzodiazepines. Now, a patient, question number 2, a person has binge alcohol consumption, developed altered sensorium with psychotic features. He will respond to glucose, IV fluid with thiamine, gastric lavage, antipsychotics. Okay, here they haven't mentioned anything about the blood GRBS of this patient. So if the patient, if he's not having hypoglycemia, it's unlikely that the patient will respond to glucose. And the features here, the clinical features here are not suggestive of a chronic alcoholic use, which would have more favored Wernicke-Korsakoff encephalopathy, all right, or Wernicke-Korsakoff syndrome, all right. Here, there is no such history also. So thiamine would not be the right option here. Gastric lavage is usually not effective in alcohol consumption because alcohol is very quickly absorbed from the stomach itself. So it's very unlikely to be useful. Then the condition here that they are saying is actually alcohol-induced psychosis or alcoholic psychosis. All right. And the treatment for that can include benzodiazepines as well as antipsychotics. Okay. So the answer here would be antipsychotics rather than any other options here. Question number 3, a patient presented with alleged history of caustic acid poisoning. What should not be done? A is awake oral intubation. You can go for awake oral intubation. Then blind nasal intubation. Blind nasal intubation is also possible, although it's extremely difficult, even if it's not a caustic acid poisoning. Awake oral intubation, it can be useful, especially if you're suspecting difficult intubation, gastric lavage, then endoscopy. All right, endoscopy may have a role in caustic acid poisoning, but what should not be done is gastric lavage. All right, because introduction of the gastric lavage tube can itself cause perforation in a weakened gastric or esophageal mucosa from caustic acid poisoning. All right, and lavage can also cause aspiration, just like hydrocarbon poisoning or kerosene poisoning. Caustic acid poisoning lavage can also cause aspiration. All right, so the answer here, what should not be done is gastric lavage. So if you look at the contraindications of gastric lavage, the main contraindication, absolute contraindication, is depressed level of consciousness for a patient who cannot maintain or protect the airway. Then you can see the other relative contraindications. It includes caustic ingestion also. Okay, so that's the answer here. Question number 4, a patient was brought to hospital suspecting to have alleged history of poisoning. ABG shows pH of 7.1, bicarbonate 15, anion gap of 18. So there is high anion gap, metabolic acidosis. Which of the following is the least likely substance? Ethylene glycol, lithium, methanol, and ethanol. Okay. three alcohols are there, and we know all these three alcohols can cause high anion gap metabolic acidosis. So the answer here will be lithium, which actually causes a low anion gap metabolic acidosis. All right. Lithium is an unmeasurable cation when you are measuring anion gap in your ABG machine. All right. But to compensate for that unmeasured cation, there will be body will retain more of chlorine. This will increase the measured anion. So the anion gap will be on the lower side. All right. So that's why lithium causes low anion gap metabolic acidosis. Now, the other causes of high anion gap metabolic acidosis, you must be remembering the mnemonic cat piles mud or cat mud piles. Okay. Question number 5. A farmer was brought to hospital. He is very agitated. On examination, his pupils are pinpoint. Excessive salivation and lacrimation is present. Wheeze is also heard. Next step in the management. So this is pesticide or OP poisoning. All right. Organophosphate or carbamate poisoning is the presentation here, condition here. Okay. So what is the next best step? IV fluid or and benzodiazepine for agitation. Physostigmine, which is an antidote for atropine poisoning or anticholinergic poisoning. Then atropine infusion, gastric lavage. Again, gastric lavage it doesn't have much role and it's relatively contraindicated in pesticide poisoning or OP poisoning. Then physostigmine is an antidote of anticholinergic toxins. IV fluid benzodiazepine for agitation can be given, but IV fluids is not the answer here. So the next step in the management would be the antidote for cholinergic syndrome, which is atropine infusion. Okay, so that is the next best option here. So remember the cholinergic syndrome, rest and digest of fluids coming from every orifice. You can remember by the mnemonic dumbbells or then sludge is there and killer bees also is there. All right. So all these are signs and symptoms of cholinergic toxicity. Now, question 6. A person was brought to the hospital with alleged history of consumption of handful of unknown seeds. On examination, pupils are dilated, urinary retention is present, agitation, patient is agitated, pulse rate 120 per minute, so tachycardia is present, temperature is also slightly elevated. So what is the next step in the management? Naloxone, physostigmine, IV fluids, and benzodiazepine. Okay, so the toxidrome here is that of a, what do you think? The toxidrome is that of anticholinergic toxin. Okay, so some of the features are suggestive of sympathomimetic toxicity as well, but they don't mention any diaphoresis here. Plus, the patient has consumed some unknown seeds, which is most likely to be Atropa belladonna. Okay, so it would be containing atropine. All right. So remember, the answer here will be physostigmine, and remember the anticholinergic toxidrome where there is hypothermia, flushed skin, dry skin, dilated pupils, delirium, hallucination, urinary retention, and tachycardia. Okay. Question 7. A patient suffering from pneumonia landed in sepsis. He became severely cachexic, associated with increased inflammatory markers. What is the treatment plan to prevent muscle atrophy? Okay, so a patient in ICU having signs of malnutrition. Okay, what is the nutrition strategy they have asked? Option A, avoid high calorie diet to prevent refeeding syndrome, which is a true statement, but is that the option here? Is that the best option here? We will see. Give TPN and check response. Okay, just because the patient is in the ICU or is having sepsis, you do not have to go for TPN. All right, only if enteral nutrition is not possible or is not sufficient, then only you will go for TPN. High protein, calorie dense enteral diet to manage sepsis. All right, high protein is required, but calorie dense diet is not actually recommended. So the right option would be high in protein, but limited in glucose, lipid, and fluid volume. Answer D would be the right choice. This is hypocaloric nutrition. All right. That's the current recommendation. Okay. So this is the general approach to ICU patients. nutritional status. Okay, so you start at a low calorie, hypocaloric nutrition, hypoproteinemic nutrition, and you increase the target by around day 4. All right. And to prevent muscle atrophy, you can increase the protein content, high protein diet, but hypocaloric nutrition is recommended. Okay, so these are the benefits of permissive underfeeding or hypocaloric nutrition. Now, question 8 again from nutrition. A malnourished patient started on TPN. He developed speed edema and altered sensorium. Which electrolyte abnormality is least likely responsible for this? Okay, so the question here is suggestive of a refeeding syndrome, which happens when you give large calorie as well as large sodium load by TPN to the patients. All right, it can result in hypokalemia, hypomagnesemia, and hypophosphatemia. All right, this is because of hypovolemia as well as volume retention because of the natriuretic effect of the large insulin release from the large metabolic load or caloric load you are giving to the patient through TPN. All right, so hypokalemia, hypomagnesemia, hypophosphatemia, they can cause pedal edema indirectly by causing heart failure. Then hypomagnesemia, hypophosphatemia, they can cause altered sensorium as well. All right. But here, hyponatremia would be the least likely abnormality present because we are giving high sodium load through TPN. Okay, usually the sodium load is much higher. All right. So the answer here, the most likely option would be hyponatremia. Okay, so they are talking about refeeding syndrome, a very important topic. Last and final question is regarding QSOFA. Which of the following is not a component of QSOFA? We know the answer here is going to be procalcitonin. All the others, respirate more than 22 breaths per minute, altered mental status, systolic be less than 100 are all parts or components of QSOFA. Okay, QSOFA was initially recommended as a screening tool for sepsis, but now it's not. Its use is being questioned. It's not that validated for the same. It has been validated as a prognostication tool, but not as a good screening tool for sepsis. All right, so currently it's not that recommended. Okay. So those were the questions which were asked in the last medical paper from emergency medicine and critical care. If you have any questions, I'm happy to help. You can contact me anytime. This is my WhatsApp number 9567 522 186. All right. Thank you so much. A very good night to all of you.